right. Well, it's exciting to be here. As John was talking about, I really do think this is an exciting transformational moment in the field. I think all of us here have been impacted by Alzheimer's disease in some way, and we've all been working really hard to get to this point. So I think we should kind of celebrate that we have one approved, fully approved medication now. And I suspect very soon we're going to have more. So this is really amazing. So the next question is, how do we get these things to patients? Because biomarker testing, I think, is going to be the biggest bottleneck, at least initially, to getting these treatments to patients. So I really appreciate being involved in this group, and I'm presenting on behalf of Workstream A, and I see some Workstream A members in the audience, including Steve Salloway and Doug Galasco. Unfortunately, Oscar Hansen couldn't come. Also, Anna Pereira, and Gil Rabinovich were participating in our many different meetings. So we're all highly motivated to make this work, and so I feel like we've made a fair amount of progress, and I'm going to describe some of that to you. There are some really unique benefits of blood-based biomarkers, and I'm going to describe some of those to you, and we've all been talking about that. And we've also talked about how can we use these things appropriately, responsibly in clinical care. We have a poster, thanks to Chi, at this conference, and we've developed target product profiles for using these blood-based biomarker tests, both as a triaging tool, and I'll talk about what that means, as well as a confirmatory test. And we've even drafted a manuscript, which is nearing submission. So I feel like we've done quite a bit. So here we go. Let's talk about why is it that we are so excited about these blood-based biomarkers? Why do they represent a transformation in clinical care? So I'm a dementia specialist, and I see patients on a weekly basis who are coming to see me with memory and thinking problems. And I would say that most patients presenting with cognitive issues, maybe 5% or less of them get biomarker testing, because the sentiment has been whether the test is positive or negative, it doesn't matter. It's not going to affect the management or the outcomes. But with drugs being available, that really changes everything. But this is going to be really hard, because this is not how we've been practicing medicine for the past 20 years. And it's going to be really hard to do biomarker testing on the scale of people that are affected by Alzheimer's disease. So there's not really numbers available on this, but I would guess that clinical biomarker testing is performed in maybe 10,000, 20,000 people a year in the US, not very many. In my large dementia specialty group, we do 7 people a week typically, which is a lot compared to a lot of other centers. So what we're talking about is instead of doing 10 or 20,000 tests per year in the US, I think we really need to get to hundreds of thousands of tests. And how on earth are we going to do this? Amyloid PET is just not going to work. I've ordered one amyloid PET scan in the past 3 years because it costs $6,000 out of pocket. And it's, we just don't have the capacity of scanners. They're very expensive. They require highly trained personnel. And lumbar puncture. So I coordinate our lumbar puncture clinic, and it's a lot of work. Lumbar punctures are very well tolerated, but it is a very different matter than just sending someone to a lab. And so I think the only way we're going to get to the kind of scale of biomarker testing that we need is by doing blood-based biomarkers. So that's why we care so much about this topic. That's why we're here. Of course, we've all had our blood drawn. It's widely available. It has a relatively low burden for providers. You don't need a neurologist or a fancy PET scanner to do this. Most people see blood collection as relatively non-invasive, typically no adverse events. Another issue that I think is important that sometimes isn't appreciated is that blood-based biomarkers may enable greater access to biomarker testing and therefore disease-modifying treatments for medically underserved or minoritized groups. And I can certainly tell you that there's evidence that these groups are not so excited about amyloid PET scans or spinal taps. And I think that one way we can help bring these drugs more broadly to the population is by using blood-based biomarkers instead of these other methods of testing. So next I'm going to talk about some of our key takeaways. We've spent a lot of time talking about all these issues, so I'm just hitting a couple highlights. But we've spent a lot of time talking about how would we use these, both in initial care, primary care, as well as in secondary clinics, so dementia specialty clinics. And we actually had quite a lot of agreement, I would say, in general, about how these things could be used. So in initial care and in secondary care, just like anytime you go see a doctor, you need to have a history and an exam that should be relevant to the disorder being treated, in this case, cognitive impairment. Now, we do have significantly higher expectations for a dementia specialist, so they should perform a much more comprehensive clinical assessment. This assessment may be much more limited if it's provided in initial care. However, it should support, it should be good enough that we have some idea that the patient has some risk for having Alzheimer's disease. We also should convey to the patient risks and benefits of a blood-based biomarker test. Getting these kind of test results is a big deal for a lot of people. It has a lot of implications for them, and we need to make sure that they understand that before we do the test. Also, something that we discussed a fair amount is that we should not make referral to a specialist contingent upon the results of the biomarker test. And one reason for that is that a lot of the patients that dementia specialists see don't have Alzheimer's. And so we don't want to close the door on anyone, close the dementia specialty door on anyone. But these tests can be helpful to better tell us who needs to see a dementia specialist. Apparently they don't agree, but so we started this with some kind of general ideas in our mind about what kind of blood-based biomarker tests may be available within the next several years. And we also use FDA-approved CSF biomarker tests as kind of a benchmark. So we're using CSF right now in clinical practice. If the blood tests are performing as well as the CSF tests, it seems like it would be reasonable to use the blood tests. We've also considered some other approaches, especially those championed by Oscar Hansen, and he's done some work with Kai Bleno's group as well, looking at 2 cutoffs so that you have 3 results, a positive, a negative, and a determinant. And if you do that, you actually can essentially make blood tests a little bit better. And actually there's a CSF test right now, the Lumipulse test, that does just that. We also have spent a fair amount of time talking about how the interpretation of the test is influenced by what we call the pretest probability, or the prevalence of amyloid in our target population. This is actually, it makes things relatively more complicated because this pretest probability varies across patient types and care settings, and it really does have an impact on what you can conclude from the biomarker tests. So what did we decide overall? And of course, there's more nuance to this that will be outlined in our manuscript. But we talked about how you would use blood-based biomarkers in what we call triaging. And what triaging means is you do a blood test, and then after the blood test, you have a second test, either CSF or amyloid PET, that's more established. So you're using the blood test as a first step. So when using this in initial care, this would allow you to identify patients who are unlikely to have AD if they have a negative result, and to identify individuals who may be at high risk for having AD because of a positive result and benefit from a referral to secondary care. Now, in secondary care, like at the dementia specialty clinic, you can also use this to identify individuals who are unlikely to have Alzheimer's disease, so a negative result. And also to identify patients who are likely to have AD, a positive result, who you then go on to perform a confirmatory test on. One thing I would say about this triaging is, especially if you have a low pretest probability of the patient having AD, these triaging tests can really cut down on the number of referrals to a specialty care provider, which is really important because we're actually really inundated right now, and we need to be able to focus our resources on patients where they really need to see us. We talked a lot about the performance characteristics of tests that we would recommend using. And I would say we think you need a good test, and I think different people may have somewhat different thresholds, but our group thought that the blood-based biomarker test should have at least 90% sensitivity and 85% specificity. This is a really high standard, and let me just make that clear. We're not talking about, sketchy blood tests that we're not sure if we believe or not. This is a high standard of performance. Just to give you a comparison, the FDA-approved CSF tests perform at about 90% sensitivity and 90% specificity. Now, there are some ways, as I mentioned, with the two cutoffs to kind of improve the performance of the test. So I think it may be possible for a greater number of tests to achieve this bar, but this is a high bar. One additional caveat to this is if you're in a place where you have better access to CSF testing or amyloid PET, you may be able to drop that specificity a bit. Because if you have lower specificity, you're going to have more false positive results, but if you can do an amyloid PET or CSF, that may be okay. So this is the triaging. What about confirmation? What does confirmation mean? So confirmation means you do the blood test, and that's the result. You don't do a second test. That means you have to have really high confidence in this test. And really, we can only use the highest accuracy blood tests in this way. Of course, individuals who are amyloid negative, that would be shown by a negative result, and individuals who are amyloid positive would have a positive result without a second test. You can still use the two cutoff scheme with that to identify individuals who are in that intermediate range. For this to really work, you have to be using the blood test in this confirmation way in patients who have a higher pretest probability of brain amyloid. And again, we're setting a very high threshold for these tests. So we're saying that a confirmatory blood-based biomarker test should have at least 90% sensitivity and 90% specificity. Again, this is the bar that we're using right now for these FDA-approved CSF tests. So a high bar. I would say we think this is achievable. There are some tests right now that are available that meet these standards. And especially for some tests, if they apply this two cutoff system, I think they will be able to meet this bar. And that the blood tests just keep getting better and better. So I think that we will be able to achieve this, which is really exciting because we really need this for our patients. So next, we're going to have Chi and Michelle talk with you about the findings of Workstream B. Thank you.